Thank you. It's a pleasure to be here, and I was honored to have been asked to come talk to you a little bit about the future of surgery. I have a number of different roles in the health system in Greenville, and we'll kind of hear about that as I go through my discussion. Um, these are my disclosures. Greenville Health System is the largest not-for-profit healthcare delivery system in South Carolina. You can see the numbers. We're now at about 1,000 physicians and 500 extenders, 7 medical campuses, medical school, numerous residency and fellowship programs. These are some of our campuses. This is the Simpsonville Medical Campus, which is where we do a lot of the surgery, primary bariatric surgery, and some orthopedics and a variety of other service lines. And I have the pleasure of actually running this hospital. So about 5.5 years ago, as a practicing bariatric surgeon, I took over as an administrator and run this hospital as the president of this hospital and sort of function in the role of a CEO of the hospital. And as a result of that, I'm also involved in a number of other administrative functions. I spend some time as the chair of our Quality and Patient Safety Council for the organization, so that spans across all of our campuses. And I also have a role in our bundled payment reimbursement model system, and innovative reimbursement models are the new wave, and so I've had some experience in working with those as well. This is, again, another picture of our hospital. So what does a physician do when he gets to the boardroom? 5.5 years ago, I made the leap. I kind of went to what we would consider the dark side by being an administrator and not just a clinician, although I do spend time continuing to do my clinical work. It's only about 20% of my time now, and 80% of it I spend. So I initially went and said, how do non-physician administrators think? So I sat around the table for the first several months that I was there, kind of listening to folks who are administrators and who spend their lives and their careers running hospitals, just trying to figure out how do they think. And that quickly became, do non-physician administrators think? Because at that point I thought, what I'm listening to doesn't really make a lot of sense from the clinical side, and I'm not really sure they're thinking about things at all. What it turns out is that they're really thinking about things in the sense of looking at dollars and reimbursement and maximizing and minimizing costs. But it's really not oftentimes patient-focused. So what a physician administrator brings to the table in our world is the ability to really look carefully from the patient's perspective to make sure that we're providing high-quality care, we're driven by outcomes, and we're being certain that that's all being done within the confines and within the construct of running a successful healthcare organization. And so the difference I believe I can make in that is to bring that physician piece into it, to remember, to try to continue to remind everyone that we are there to take care of patients, and that oftentimes a lot of the cost issues and the quality issues really should be driving what we do, rather than just looking simply at whether something costs more or less than something else. So with that being said, the reality is, of course, we all know healthcare is changing, and I know that this is really in the civilian world, but I suspect that this will parlay into the military world as well over time. For those of you who watch Downton Abbey, and I'm not much of a series watcher, but my wife watched it and sort of dragged me into it, and there was a butler named Mr. Carson who had a number of very, very intuitive lines throughout that entire series. And he said the nature of life is not permanence but flux. And I think those of us in medicine realize now that there is no normal. We are now in the new normal, and the new normal is going to change again next week, and it'll probably change again next year, and it'll change again several years from now. So we just need to get used to this constant state of flux where nothing really ever is permanent. We know healthcare is changing. So we've started out living in this fee-for-service world, and we still live in that fee-for-service world, and we'll talk a little bit about that today, where the more you do, the more you get paid, the more you get paid, the more the hospital makes, the happier everybody is. And making those dollars allows us to reinvest that money into certain other things. But that world is changing, and it's changing pretty quickly to this world of at-risk payments. And we're seeing, and we'll talk a little bit more about that in a few minutes, but the world of at-risk payments is a totally different world where we're being asked to take care of populations of patients. When I listened this morning to some of the discussion about the members who have TRICARE and the folks that you take care of in the non-trauma world and in the non-combat world. And the reality is those are at-risk payment models as well. And I think we need to begin to look at this and say, well, there's a certain amount of money we have to take care of all these folks. We have to become better stewards of the dollars we're spending and better stewards of the dollars that we receive in order to make sure that we remain financially stable and viable and can continue to take care of the people we need to take care of. And that's really where at-risk payment comes into play. So I think the most dangerous phrase in the English language, according to Rear Admiral Grace Hopper, was "we've always done it this way." And again, we can't continue to just do it the way we've done it. I think the folks who are going to see the majority of this are the ones who do a lot of elective type things. So for instance, I think in the new world, when we go from a fee-for-service model to an at-risk model, lots of changes in the way we do things. A 53-year-old with knee pain who now gets an arthroscopy because an arthroscopy makes dollars. It's something the orthopedists do. The orthopedists need to generate revenue. They generate income by doing that. In the world of at-risk payments, when we get paid a certain amount of money to take care of that 53-year-old for the entire year, that becomes a cost instead of a revenue. We're spending money out of our checkbook that we have loaded up with that person's at-risk payment, and we're spending it on doing things like arthroscopies. Or instead in the future, it may be Mobic or physical therapy and no Mobic. It's now today it's an arthroscopy. Arthroscopies are expensive, and you're going to see how expensive some of the stuff we do is in a second. So we begin to have to think about it that we're going to have to do things differently. So if we look at the business model of medicine, we've kind of lived in the left side of this, fee for service. The more procedures we do, the more money we make. We generate more revenue. We want patients to be in the hospital. We want to continue to keep our hospitals full. We're really moving slowly, and in some cases quickly, to the box on the right. Risk-based payments. We're looking at managing populations of people. And we now have several contracts in our area for 100,000 patients and 90,000 patients where we're managing that entire population for an entire year. And it's almost like an insurance product, although we don't call it insurance. It's really based on managing a population. Controlling expenses, which is really the drive of what I'm going to talk a little bit about, and growing everything on the ambulatory side. We have 1,700 beds in our healthcare system, and that's going to be way too many several years from now. And really, we all know that we're taking care of people. 30 years ago, if you had a hernia repair, you were in the hospital for 3 or 4 days for a routine inguinal hernia. Now that's done outpatient, and folks are home in time to watch late morning television. And things are different. We're doing a lot of things outpatient. I'm a bariatric surgeon. We're now keeping people 1 night instead of 3 nights. And I suspect we're going to be doing that stuff outpatient at some point in the future. So it's really just a matter of understanding that we're moving to this ambulatory world. And there's a variety of reasons for that, not necessarily bad, but that's just sort of the nature of what we're doing. But it's difficult to transition these business models, and if we look at kind of some of the things that have gone by the wayside as business models have changed, travel agents, record stores, independent bookstores, typewriters. Maybe there's some still left in the military, but there's really no typewriters really that we use anymore, although I learned how to type on a typewriter many, many years ago in middle school. Video stores, most of them are empty shells now. And so if we don't really begin to bridge that gap between transitioning business models, we're going to wind up, unfortunately, like a lot of those other enterprises. So what's the basis for the transition? We've got to really look at everything based on value. So the value equation is kind of how we look at things. And what I've brought into that discussion in the boardroom is all based on the value equation. And that's defined as quality over cost. So what brings value either increases quality or decreases cost. What I will propose to you, however, is that we can also bring value if we increase cost by being certain that whatever we're doing cost-wise is overshadowed by how much we're increasing the quality of the end product. And that's where we talk a little bit about reducing complications and things that will cost money to do, but over time will improve quality to a degree greater than the cost, thereby meeting the basic tenets of the value equation. So as surgeons, we face an ongoing need as clinicians to improve quality and outcomes. We know complications are costly. Many of us don't really even know how much these things cost, and I think this is both in the military world and in the civilian world. We don't talk about how much stuff costs. It's usually not an issue. If I'm a surgeon, I want what I want, I get what I want. If I don't, I stomp my feet. If I don't stomp my feet loud enough, I'll stomp them louder, and I'll eventually get what I want. In the civilian world, it's if you don't give me what I want, I'm going to go take my cases and do them somewhere else that's going to give me what I want. The reality is that we have to be very careful to look at these kinds of things and realize how much these things cost. So complications are costly based on, diagnosis, treatment, and then the world we live in of liability for both the physician and the hospital. So I want to define what costs and charges are, and there's a difference, and this again is in sort of the world that we live in. Costs are the dollars that we spend to perform a procedure, a test, or an intervention. That's what's actually it costs to do that. To do a CT scan, there is a cost to the machine, to the equipment, to the technicians, etc. Charges are what we see or the patient insurer sees on the hospital bill, and there's typically a ratio of about 3 to 1. So charges are an unfair way to look at this. We really have to look at cost. So let's look at the cost of bleeding. So if we have bleeding, a type and cross costs $160. And if I ask, we have 180 surgeons in our department. If I asked 180 surgeons, I bet you not one, probably other than me, could tell you what any of these numbers are. So this isn't stuff that's well known, but it's what we have to get people to understand. Giving a unit of red blood cells costs $420. A reoperation costs somewhere about $25,000 or more. And the cost of staying in our hospital, which is nowhere near as nice as the hotels we're all staying in here, costs about 10 times as much. It's about $1,500 a day to upwards of over $3,000 a day if you're staying in the ICU, you're monitored, and you have a variety of other things going on. So it's very expensive to be in the hospital. If we look at internal hernias, so here's the bariatric surgeon's nightmare. I don't know if any of you are bariatric surgeons, but this is the CT scan and the operative findings we don't want to see if we can help it. We look at an internal hernia and the cost for that. So they're very difficult to diagnose, as any of us who do this or live in this world will know. A CT scan, about $5,600. Now these are charges for the OR, $9,000, but I'll get to how much the OR actually costs in a few minutes. Every additional 30 minutes, we charge $2,000. We charge for the hospitalization. That's $20,000, $25,000 plus $1,500 a day or $3,000 a day for a room. Possible need for bowel resection, catastrophic events that may occur as a result of this, and the legal costs. So the number one thing that we're seeing now on the legal side, the number one liability in bariatric surgery is a missed internal hernia with a disastrous outcome. And I am a reviewer for the defense, and I look at a number of cases each year, and this is what they focus on, is missing this diagnosis. So it's very costly. We did a random sampling of how much this actually costs in the world we live in, and you can see the numbers there. A low of about $23,000 to a high cost of about $775,000. And that was even more because this patient eventually went on to have a small bowel transplant. I can't even imagine what that cost. It was done at a different organization. But the average cost of this is about $42,000. Remember, we're going to get a checkbook now, and we're going to fill it up with what we're getting paid to take care of these people for an entire year. And we're spending $40,000 on average to take care of a complication from a surgical procedure. Staple line leaks, again, same sort of thing. Financial costs can be significant. So we looked at Truven Analytics, which we looked at sleeve gastrectomy patients across the entire country, de-identified data, looked at things like reoperations, diagnostic testing, etc. And in the end, we identified 64 leaks in this group of patients that we looked at, which was about 1.3%. That's a number that's probably pretty true. The mean total hospital charge was $140,000, but for patients who had a leak, it went up to over $850,000. And so again, very, very expensive. And we're probably, at least in our world, not going to be paid for this in the future. When we reoperate or readmit these patients. So we're talking about very, very expensive complications. So why should we reduce complications? I think all of us need to measure our value to the system, and our value is being measured for us. And I suspect if this isn't happening where you are now, it will eventually happen. That we will look at things like time, supplies that we use, complication profiles. We're tracking things internally using scorecards for our surgeons, and they're tracked externally also by a number of our favorite sources. And so people can go online now and find out anything they want about you. If you Google yourself, you'd be shocked to see what you find. And I suspect that this will get only more interesting over time. We all know that patients who fill out surveys are usually the ones that are disappointed or disgruntled, and so that skews a lot of these results. But this is where folks are getting, this is the court of public opinion. This is where they're going to get their information. The other reason we need to reduce complications is because we're getting into this world of population health, as I mentioned earlier. We used to call it capitation, now we call it population health, but it's basically the same thing. We're being paid a certain amount of money to take care of a certain group of people for a certain period of time. Bundled payments, and so we're now in bundled payments for several medical diagnoses, for several surgical things, including total joint replacement of the lower extremity, and it's estimated that by 2018, 70% of our care that we deliver will be in a world of bundled payments. So what about bundle payments? For those of you who don't live in the world of DRGs, DRGs didn't exist years ago and now they do. So diagnosis-related groups were ways that we said this is a patient who's admitted for these diagnoses. That's how we're paid on the hospital side. That's where the dollars come from. And bundle payment is the same thing. Here's an amount of money you get to take care of this patient, to do a total joint replacement of the lower extremity and all of the care that you provide to that patient for 90 days afterwards. If we readmit that person, if we have to reoperate on that person, if they have a complication like a DVT or pneumonia, whatever it may be, that all falls on the provider now, not on the insurance company, and in this case it's Medicare. So I suspect that the future is going to be littered with a lot of this stuff. And the future of physician reimbursement is moving from that volume to value, so we're going to be paid by our performance, our outcomes, and our quality. So I think we have to do whatever's clinically sound to reduce these expensive complications, be aware that our data is being tracked, use nationally recognized benchmarks, and participate in PI and QI projects in our areas. So what about costs? So what are the cost drivers? We're all told that we need to be really fast in the OR because OR is expensive. In our hospital, the hospital I run, it costs $3 a minute to be in that operating room. And that's a true number. And if you think about it, that makes sense. It's $180 an hour. That pays the nurses. It pays to keep the lights on. It pays for the air conditioning to run. $3 a minute. So is faster better? It's not necessarily better unless the savings in time, or I should say, if the savings in time are outweighed by the cost of sloppiness. So doing sloppy surgery and having complications and bad outcomes will quickly eat up all the money we've saved by being a little faster. And it's important to the overall cost of the case, but it's not a primary driver. So what's the cost driver for what we do as surgeons? The stuff we use. The stuff we use is really expensive. General supplies, 4x4, probably not terribly expensive. A stapler, very expensive. So a stapler's about $300. And every reload's about $150. And if we ask the surgeons will say, I want 2 staplers because it'll make me so much faster. And the reality is, if a stapler's $300, if that second stapler doesn't save you 100 minutes of time, and I suspect it doesn't, then we really can't afford, you're not going to get that second stapler. And this is the world we kind of live in because as a hospital, I'm getting paid one fee to take care of that patient. If I start doing more stuff with more things, it doesn't really add up. And lots of talk around this with our surgeons, with discussing this with our surgeons and having them educated and understand this, and they're willing to comply. This isn't something that's being told for them to do. It's just getting them to understand that we really don't have the ability to just kind of have all this stuff anymore like we used to. In the days of old where everything was opened and all kinds of things got thrown away at the end of the day really are kind of gone. The gadgets and the gizmos, the suturing gizmos, you're going to see a bunch of them in the exhibit hall. We've got something that'll do everything now that you can't do manually because we've got gadgets and gizmos to do it. Very, very expensive. Staple line reinforcement, also expensive. We now know, though, that when we use staple line reinforcement for what we do in bariatric surgery, we can reduce the complication rate. And if you do the analytics of that data that we've pulled, you realize that we can actually not cost money because we meet the value equation. The quality goes up even though there's some cost. So there's certain things, again, where spending money makes sense. So I think from the standpoint of what should we do, we should really drive all this by what we can do to reduce complications. I think we need to interact with folks who make these decisions using clinical data, need to be sure that we are really using sound judgment and sound data to drive our decisions and really not be tempted to buck the system. So what about payment? The current model's not going to work. We submit a bill. That bill has changed when we've gone from ICD-9 to ICD-10. We're now asked to really, really hone in on the kinds of things we're doing and what we're doing for patients. That bill is generated based on all of those codes. So coding our procedures correctly, coding all of the pieces and parts of our procedures, making sure that we are as accurate as possible helps to generate that bill. But even so, we're only paid based on whatever the DRG is for that particular admission. So an uncomplicated bariatric surgery has a certain DRG, we get a certain payment. The hospital, I should say, is the one who gets the DRG payment. The physician in our world submits a bill, gets paid, but it's all pre-negotiated. It doesn't matter, but we have to be very careful about our coding to substantiate that bill. On the hospital side, outpatient, it's a percent of charges, and inpatient, it's a DRG. And on the inpatient side, a lot of what we do is Medicare designates as inpatient only because it's a whole lot less expensive for them to pay you one payment rather than to pay you per item and per piece. In the future, there's no question that our salaries are going to be tied to the margins of the hospitals. We're seeing that happening now, whether we are employed, affiliated, independent, and I suspect this is coming your way as well. It's really a matter of trying to keep, it's running a business, and unfortunately, we've got to make sure we take care of patients first, we run a business next, and we check kind of the emotional piece at the door. Lump sum payments, this is part of the bundled payment and gain sharing, and we are really in control of our own destiny. We deal with the governmental alphabet soup. So we've got HCAPs and CGCAPs, and I don't know whether this extends into your world or not, but patients who get in the hospital have to fill out surveys. The HCAPs are the hospital surveys, CGCAPs are how we do in the office. We've got value-based purchasing, bundle payments, advanced alternative payment models, advanced alternative payment models, MACRA, MIMS, CHIP, and eventually you're just like, what in the heck am I supposed to do with all this? How do you put anything behind any of this to make it make sense? Patients are going to drive a lot of this, and you'll see in a second. But remember that 3 out of 4 patients rate their quality based on their perception of care, not the kind of care we deliver. So we have to really improve the patient experience. It's no longer a can-do, it's a must-do. MACRA is the new wave. This is a bipartisan bill. It is not going to go away no matter who's in office. We don't anticipate this to go away. It changes our reimbursement. The data period for reporting, for collecting data has already started. It has 2 payment models, and I'm not going to spend much time on this, but just realize it's incredibly confusing. The piece of it that makes a difference is not how the fee schedules work. We as surgeons are going to be tied into one of the 2 fee schedules, and it's not going to really matter how that all happens, whether it's MIPS or AAPM, it won't make any difference. I don't think studying this and understanding this thousands and thousands of page document makes any sense. What we really need to know is what's being weighed, how are we being looked at? And it's really, as you can see, based 50% on quality, 10% on cost. Those numbers over time will change. So if we look at quality, they're talking about outcome measures, costs. How much does it cost to take care of these patients? What are we spending per beneficiary? Clinical practice improvement. So this is care coordination. Using what I heard this morning, you have a new electronic health record, using the new electronic health record. Cost and resource use starts at 10%, goes to 15%, and eventually to 30%, and quality kind of tracks right there with it. So those are the big issues. I don't think it's important to understand the nuances as much to know they are going to base it on cost and quality. What does it cost us to take care of people? What's the quality of the outcomes? We as surgeons will likely not qualify for the advanced alternative payment model, so we'll wind up in the MIPS side of this, but again, not necessarily important to understand that. I think it's important to realize we need to maintain the ability to control our payments, our salaries by managing our behaviors, focus on providing value by improving quality, reducing costs, or as I said earlier, only doing things that cost if we can show that they improve quality to a higher degree. So our success, we were always taught about the 3 A's being able, available, and affable. There's a 4th A now, so we need to be able, affable, accessible, and affordable. We have a responsibility to be well-trained and provide high quality. We must deliver an excellent patient experience. We must provide care when it's best and most convenient for our patients, and we have to maintain our fiduciary responsibility to be financially competitive. The sweet spot really isn't being physician-centric or patient-centric anymore. It's not a matter of us versus them. It's really a we, and the sweet spot of success is right in the middle. We've got to realize that this is a joint venture for us and the patients to make sure that we are doing the best job we can to give them the best outcomes. So again, healthcare is changing. I think the way to tether ourselves to this new side of healthcare is looking at costly complications, being mindful of what things cost, understanding it, asking questions. Hopefully your new electronic health record will provide you with the data that something like we use Epic will give us data about what things cost, and play an active role in these decisions, but make sure those decisions are grounded on the idea of the value equation. And I think it's important for us to know we all do a good job, but don't be afraid to give up the good to go for the great.